this meeting. Okay, we're recording. Okay. No dead air space now, Jake.
Okay.
You know what they say about dead air space.
You're right. Don't want to waste it.
That's exactly right. So let me see. I have to look and see when Steve's birthday is. No. Could be the same. Could be the same day. So how's the traffic? Are you stuck in traffic? Are you on the bridge? Where are you, Eric?
I'm on the on-ramp to the bridge, and I've been on the on-ramp the whole time we've been talking.
I'm sure you have. I'm sure you have. I feel for you. Indeed, I do. There's a lot more traffic here than there is in South Florida, Mr. Cameron.
I'll tell you, this time of year, though, Rick, it's really building up, and it's only November.
Now, tell us exactly what really building up means, because I'm sure Eric, who's stuck in traffic trying to cross the Bay Bridge right now, would like to hear. Because it's
well, if you want to go up to Sarasota, which is 25 miles away, usually out of season, you can do it in 35 minutes. It takes you about an hour now.
I see. About twice as long, huh?
Is that because
in the downtown shopping areas during the course of the business day?
Yeah.
Forget it.
Okay.
Plus, you got to remember too, most of all the drivers here are above 65.
Yeah, but you know, so are we. So we have to be careful.
Oh, I know. So it's hard to complain anymore.
I know. It used to be, you know, watch out for those old farts, but well, now it's the
when
ones.
When I first got here, I was 58. You know, I used to say, "Hey, watch them people."
That's right.
Now I'm one of them.
Yeah.
Yeah, but now he is one.
I know. It's those ones that are over 90 that are the problem, that can barely see over the wheel. They're the dangerous ones, you know.
But you got a lot of old ladies down here driving these big Cadillacs, and all you see is their eyeballs right over the top of the dashboard. That's all you see. You see this big Cadillac coming down the road at you, and you think there's nobody in it.
That's why they have those beehive hairdos, you know.
Yeah.
I was listening. It's funny you say that. I was listening. They replayed an interview on Morning Edition this morning with Mel Brooks, and he was talking about his uncle, who was a cab driver in Brooklyn. And you know, as he said, if you saw a car coming down a cab coming down the street that was driverless, it was probably his uncle because he was so short. So. So who just joined us by phone?
Jim Harrington, Rick.
Hey, Jim. Oh, I'm glad you're on. Because we have
I'm glad to be on.
Because, yes, we have a discussion point for you and Jim Cameron, who's also on right now, but we'll wait a little bit to get onto it.
Sure. Happy to help.
Yes.
How's the weather up there in Jersey, Jim?
Well, it's not too bad. You know, I mean, low 50s, and then it can get down to 30 at night. But actually, it's been pretty decent. For tomorrow, Election Day, it's going to be in the low 60s. Not bad. Really not bad at all.
Now, for that, you can play golf in that weather. It's not bad at all.
Yeah, sort of. That's right. You can. That's true. No, it's not bad.
That's how I judge the weather.
Yeah, that's right. That's right. You can use a white ball here, you know.
I've been having discussions with Cancer Care over the last week and a half or so, and I'm really surprised that they're closing their office for Election Day tomorrow. I mean, you know, I know people close their offices for President's Day and what have you, but to close an office, and they're not in a school or anything. I mean, they're somewhere in central Manhattan. So,
yeah,
I read on the internet that there was quite a few companies that were closing for Election Day this year. But I know when I was working, that never happened.
No, me neither. Me neither. So
well, apparently the lines are atrocious. In some places, the lines are, you know, snaking around the block.
Mm-hmm.
So,
You know what you're talking about down here in Florida. Fortunately, down here in Florida, you can vote 30 days before the election. After my first year down here, I signed up for vote by mail because you wait 2-3 hours to vote.
Yeah.
I voted early for the first time in my life that last week.
Well,
I'm originally from New Jersey, and New Jersey only has voting on election day.
Right.
yeah, I mean, they only have voting on election day here in California, but they have vote by mail. And when you've got in Marin, and we're getting off lightly, you've got over, I think, 17 different propositions and referendums and God knows what to vote for, and a voter's guide that's 110 pages long. It makes it a lot easier to vote by mail. I mean, it's crazy to go in and fill out that ballot. You can't, if you went in and filled out that ballot unprepared, you'd be there for 3 hours each person.
We had that situation down in Florida last time. There was 13 propositions on the ballot. The ballot was like 4 pages long.
I know, crazy. And when I went back to England, I took my voter's guide with me, and the people, my friends, couldn't believe it. They thought they just couldn't believe it. They were just astonished, and they were laughing. You know, we've got a vote on. Somebody told me 110 pages, but I'm looking. It's 223 actually. The guide that I'm holding, which is the California general election. Here, I'll put the screen on just in case any of you doubt what I'm saying here. Here.
Yeah, I was going to ask, are we going to get to see your pretty face tonight?
There you go. There you go. So now this book here, you can see. Well, those of you who are online can see, is 223 pages long. It's outrageous. I took it on the airplane with me. I felt like I'd read a novel when I got to the other side, man. I mean,
how many people don't even open it?
Oh, I mean,
I'm guessing half is in Spanish, though, right?
No, not half. I mean, some of it is in. Wait a minute, is any in Spanish in this one? No, this is all in English. This is 212 pages, all in English. How about that? Now,
just think how much taxpayer money it costs to print all that stuff.
Oh man, and let me just give you an idea of the where's my favorite, which is my favorite one. I think it's this one here. This is my favorite here. Let me just see where's the actual question that's on the. This is number 60. This is number 60, and the question on the ballot is. The question on the ballot, number 60, is Adult Films Condoms Health Requirements Initiative Statute requires adult film performers to use condoms during filming of sexual intercourse, requires producers to pay for performers' vaccination, testing, and medical examination, requires producers to post condom requirements at film site, fiscal impact, likely reduction of state and local tax revenues of several $1 million annually, increased state spending that could exceed $1 million annually on regulation, partially offset by new fees. Yes or no? There you go.
Welcome home, Nanny.
Thank you. Oh, man. I tell you. All right. So let's see. We've got a couple of people that called in by phone that haven't identified themselves. You want to speak up and tell me who you are?
Yeah, this is Ron Zechmeister. I'm on by phone.
Hi, Ron. How are you? We haven't heard from you for ages.
I know. I've been keeping a low profile.
That's okay. You're allowed. And we got one other person who hasn't identified themselves that called in by phone. Who's that?
This is Mike Tamales.
Hey, Mike Tamales.
Hey, Rick.
How you managing without your buddy? Okay?
Oh, it's like, can't wait for him to come home.
Has anybody heard from him?
No, not that I know of.
No, I know. Me neither. He's taking a very low profile. I don't know what he's doing. Funnily enough, my best friend, who I went back to England for his daughter's wedding, he left today for Vietnam and Cambodia as well. So, you know, they'll probably run into each other somewhere. Who knows? Okay.
Yeah, probably have a hard time finding the internet out there.
Yeah, that could be. Okay, well, we've got a fairly small group today, and we're all old friends. So let me just write. I haven't written everybody's name down, so I'll do that right now, and then I'll ask who needs some time. So we've got myself. We've got Eric Bookbinder on the Bay Bridge. Are you on the bridge yet, or are you still trying to get on?
Just this second got on the bridge.
All right.
Ending in front of me, and the metal is starting.
All right, success. Jake, we've got Jim Cameron. We've got Jim Harrington. We've got Jake, Jim Cameron, Jim Harrington, Mike Tamales and Ron Zetmeister. Mike T and Ron Z. Okay, so I know that Jim has something to speak about because he wrote me, so we'll kick off with that. And let me just go down the list of the other people. Eric, you have anything you want to talk about today?
Yeah, if I'm able to unmute with the time to talk, just an update on my status.
Yeah, definitely. Okay. Jake, how about yourself?
No, not really.
We have plenty of...
I'm counting on you to get something from the guy from Foundation One tomorrow.
Oh, right.
I did not pursue it because of what you said.
Oh, well, let's review that too, and it'll help me. So I'll make some notes when I talk to when I talk to David Marshak tomorrow.
Okay.
Jim Cameron will come to you. Jim Harrington, how about yourself?
Rick, not tonight. I'll just listen. Thanks.
Okay. Mike Tamales, you want to give us a little update?
It'll be a real little update.
That's okay. We don't mind how little it is. And Ron Zechmeister, you have to give us an update because we haven't heard from you for so long.
Okay. Well, I've been trundling along here, and
Okay.
Currently I'm on
hold on a second.
bicalutamide.
Hold on a second. We'll come back to you. I'll give you some time.
Okay.
I'm just going to run through everybody, but just want to give you a heads up that we're going to ask you for an update. So
You'll get it.
Thank you. So the question that Jim Cameron had for me was about accessing Myrbetriq, which is a drug that I know Jim Harrington has used. So,
No, that's right. I take it all the time. Yeah.
right. It's an incontinence drug. It works a little differently, as I understand it, from some of the other incontinence drugs in that it sort of relaxes the, in some fashion, it relaxes the bladder. At one time I knew exactly how it worked, but I can't remember right now. But maybe you remember, Jim. But Jim Cameron, why don't you put your question out there, and then maybe Jim Harrington, who has experience with the drug, can help you.
All right, I was having some incontinence problems when I was up at Johns Hopkins 3-4 weeks ago, and they told me make sure to go see a urologist down here in Florida, which I did when I got here. And he told me to try one of two drugs. The first one was oxybutyn, 5 milligrams, and on my prescription plan, that was $1 a month. The Myrbetriq on my present plan was $999 a month.
Wow.
So obviously I tried the dollar one first, and it was a disaster. After 3 days, I couldn't talk. My mouth was so dry. My lips were swollen. So I stopped it. And the doctor has just gotten me some samples of my Betrix that might almost hold me until the first of the year when I'm going on a new drug plan. But I'm wondering if anybody, I know you're on it, Jim, and I was wondering if anybody else was on it and how it worked out for them. Did they have any side effects? Did it work immediately? Or because the doctor told me sometimes it took a while for this to take effect.
Well, Jim, Jim, we're Michigan, New Jersey. I've been on Mybitrig for quite a while. Actually, Rick, I don't know that I would call it an incontinence drug so much. I mean, it's related to that, but I took it because I have an AUS, an artificial sphincter. The drug wouldn't do anything there. I've already solved that incontinence problem, but it's rather a drug. There is another drug, and it may be the oxybutynin. I can't remember. I took it and it didn't work, but really, it's all it's for is so that you don't have to get up so often at night to pee, to put it bluntly. And I think it works. Mybitrig comes in 2 doses. I take the lower dose. I thought about taking that. The only side effect that my urologist claimed for Mybitrig is higher blood pressure. It can elevate, and I don't find that happening, but I don't know. I'm kind of ambivalent about it, but at one point I thought that the amount of times that I had to pee at night without the drug was reduced by about a factor of 2, which is pretty good because, you know, we guys, we get up often at night. So that was good. I'm just not so sure. I will tell you that Mybitrig is a relatively new drug and expensive. I hadn't heard the $900, but wow. I think mine is something like a month. It's $300 or something like that. But I have to admit that I do have good insurance, and in fact, I do not pay for it. But the only danger is if you have problems with blood pressure, be careful with this stuff. I wasn't knocked out by it, but it's worth a try for all of you who want to not get up quite so often at night. So that's really, and it does. I think it's right. It relaxes the bladder, so you don't have to get up. But incontinence, I have other solutions. Always happy to help on that, and I've helped with some of you. But Mybitrig is really is a new drug that so you don't have to get up so often at night.
Did it kick in right away when you took it, or did it take?
I guess so. Yeah, I mean, I did hear that too, that it took a while. I guess so. Yeah, I can't say because, you know, how many times do you get up at night? 5 times or every hour and a half? And then I took it, and then I think it went down.
By week.
Yeah. And how much you drink during the day and when you drink it and so forth. As I say, I'm not overwhelmed by it, and if you have to pay $900, boy, I'd. But I don't have any side effects from it, and my blood pressure has not gone up. So maybe I would try the higher dose.
At the first of the year, is I'm changing drug plans for some other reasons, but the new drug plan I'm going on, I can get it for $155 a month copay.
Do you know what dose it is? Is it the
big difference?
Yeah. I mean, there's 2 doses as I understand it. I don't know what dose you're talking.
I got, my primary care doctor gave me, he had some samples, and he had me come back to the office. He got me some samples. They were 50. The urologist got some samples, and they were 25. And the urologist was telling me, I just got them. He said, he says, maybe what you ought to try is take one every other night and see what happens with that. I got an appointment to see him in 2 weeks, so I'll take it for 2 weeks and see how it is.
Yeah, I think that's a good idea, Jim. I wouldn't worry about it. It's pretty harmless stuff. I mean, I don't really have any, and my blood pressure hasn't gone up, so I really don't have any. I don't feel any side effects from it at all. Whether it's reducing the 9 times I get up at night, I guess so.
How about you don't have leakage during the day because you have the...
No. Well, see, I have an artificial sphincter, so I mean, all of us who have the AUS have to wear a pad generally because there's a very, very small amount. But no, nothing unusual. No, the sphincter really works.
I get leakage during the day if I'm not doing anything. If I'm out playing golf, I play 18 holes and probably have to find the tree twice in 18 holes.
Oh, I see. Yeah, well,
Yeah,
find a tree.
On the lanai in the afternoon, every hour I'm in the house.
It might help you then. This might really be helpful. I don't know. I mean, I don't. Yeah.
Okay. Well, I'm gonna try the every other day for 2 weeks until I see the urologist again.
Yeah. Okay.
Oh, okay.
Sounds good.
That was part one of my question, Rick.
Go
part
ahead.
two was when I went to see him. He said before I prescribed this, he said I want to examine your bladder with a and I forget the name of the
a cystoscope.
Cystoscope, right? And I went in a week or so later, and I told him, I said, I just had two CT scans in the last 3 months up at Johns Hopkins, one before my eye operation and one, I don't know, just about a month ago. And he said, well, your bladder is wrinkled, and cancer could hide inside the wrinkles. So I called Johns Hopkins, and they said, go ahead, go through with the test. And of course, they didn't have to put up with it. And I did that, and he came back and said, here's your problem. When Sloan Kettering radiated you 11 years ago, they burned the top half of, you got radiation burns on the top half of your bladder. And he showed it to me right on the screen as we were doing the test. He claims that's the problem for my incontinence problems, and which I think is BS. He claims that's why my cancer came back, because they didn't put enough radiation in the prostate and it hit the bladder. Has anybody had any problems with getting their bladder accidentally radiated? Or any thoughts on this? I haven't contacted John Hopkins about this test yet, but I'm gonna next week. I don't have an appointment with them for another couple months.
And just tell us again, what is the test again, Jim, that you want to do?
No, they did it already.
Oh, the test that they did that showed the wrinkled bladder you're talking about.
No, they showed the bladder, the top part of the bladder.
Who was Bud? Okay, that part of the test. Well, I mean, probably I would be wanting to talk to either Hopkins or maybe even to Memorial Sloan Kettering. Bill Burhans has joined us, and I also want to acknowledge that I see somebody by the name of Earl. Well, he was on and he's gone. I hope it wasn't because I didn't acknowledge him quick enough. Well, maybe he'll come back. But Bill's on. Bill,
this is a topic that's near and dear to my heart.
I know.
But I missed, the early part of the question, and so I don't understand the context. So Jim, if you could just fill me in briefly.
Okay, I had a cystoscope about 2 weeks ago.
Okay.
And the urologist said the upper part of my bladder had radiation burns when I had radiation 11 years ago at Sloan Kettering in New York.
Okay.
And he makes two claims. One claim is that my incontinence problem that I'm starting to have now is caused by that. And the reason that my prostate cancer came back is because they didn't put enough radiation in my prostate because they hit the bladder.
Okay. So what is your question then?
Well, my question is, has anybody heard of this, the bladder getting burned, and has it happened to anyone? Do they know anything about this?
I think it's a common problem with guys that have radiation treatment. It's called radiation cystitis, and I don't think that there are. I'm not aware that there's really any hard and fast cure. So the big problem is incontinence. Is that what you said?
Well, that's the problem I'm having. That's the reason I went to see the urologist, and then he suggested that I have this cystoscope, and these were the results that he came up with. You know, after he did the cystoscope, which you get results back right then and there.
Right. So what does your urologist, now that he's seen the result, what is he suggesting that you do going forward?
He claims there's not much you can do. Now, like I say, I haven't gone back. I plan on it, but I haven't gone back to Carlucci, who's my oncologist up at Johns Hopkins.
Yeah.
And Christmas time, when I'll be up in New York, I'll be up in New Jersey, New York for about 2.5, 3 weeks. I may go over to see the oncologist that did my radiation. I don't know. I haven't decided what I'm going to do yet. I don't know how common this is or not.
Yeah. So keep in mind here that I'm not a physician. I'm a cancer scientist, but I do have almost as much experience, I think, some days in this area as I do in cancer science, because I've had many of the same problems. And unfortunately, you know, I've been told the same thing, that there's really not much that can be done, but there are some drugs that, you know, I think have some potential of helping, if not completely solving, the problem. And I think they're generally antispasmodic drugs, but I'm not sure. But I would definitely follow Rick's advice and, you know, bring this question to someone at a major cancer center, which is what it sounds like they're doing, you know, at your buddies at Johns Hopkins, for example, and see what they have to say. And I wouldn't, you know, completely lose heart on this. I think there might be a solution, but, you know, I was told the same thing, that there may not be. They didn't say that there is definitely not a solution, but they said that there may not be any way to correct the problem.
I was just trying to gather everything, all facts I could get together, and I'm going to get the written report this week from the urologist, and I'm going to forward that up to Johns Hopkins, because I have a lot of faith in those people up there. But I was just wondering if anybody else that had the problem, that, you know, may give me some avenues to look into.
Bill, what was the recent procedure that you had? Maybe you want to talk a little bit about that. Maybe it's something that Jim Cameron should be aware of when he talks to his docs.
I had there were a couple of things. So the original plan was simply to do a cystoscopy, so a study using the cystoscope to look and see, you know, what the status of the damage in my urethral region was, and then the plan was to inject Botox into my bladder, and this is potentially something that could help you. So, you know, Botox relaxes muscles, which is why, you know, some people have it injected into the muscles of their face to get rid of wrinkles. But it can, in my case, my problem is spasms. You know, that my bladder spasms periodically, and these spasms are incredibly painful. So I had a Botox injection to relieve that, but it turned into a much more involved surgery than we expected, because, and this is something that may not be relevant to you, Jim.
Okay.
The urologists found a urinary stone that had been completely encapsulated by connective tissue in my urethra. and that was together with a radiation stricture. You know what those are, right?
No, I don't.
Okay, radiation stricture is basically scar tissue that's caused by, radiation damage to the urethra.
Oh, okay.
And, anybody that has radiation treatment has the possibility of developing a stricture. They're, and they basically just occlude the urethra. So I had, both the stone and a stricture that were occluding my urethra. And the surgeon had to remove, they don't remove strictures, they just slice them up to make it easier for urine to flow through, the plumbing. But in the case of the stone, they had to excise it along with all this fibrous material that surrounded it. So potentially, I'll be, this will solve a lot of problems. I've had a urinary tract infection for more than a year. Every time that I've had a urine culture since about September of 2015, it's come up positive, unless the urine was donated while I was on antibiotic, which is, that just doesn't work because a negative result is meaningless. So this has a potential of solving that problem. In fact, just having a blockage that blocks the flow of urine, can trigger UTIs because it's just a big pool of urine that's sitting there all the time, and it's a good bed for, not bed isn't the right word, but a good medium for growing bacteria. So that's an answer to Rick's question. That's what was my surgery was all about. I don't, I have, I'm not sure how relevant it is to other guys who have had radiation treatment. I had too much radiation. At the time that I went through radiation treatment, we didn't know that I had a BRCA2 mutation, and that makes all of my normal cells super sensitive to radiation. If we had known that I had that mutation, we would have used a lower dose of radiation. But we didn't know, and so I got far more radiation than I should have. And that, I'm telling you that because that means that, the problems that I've been having are not necessarily those that anybody else would have that doesn't have that BRCA2 mutation.
Now, Bill, do you recall the conversation we had on this in this group about the Botox and the formaldehyde when we raised it for you to look at? And can you recall who it was that I can't. Who was it that suggested that? Who was?
Well, I had actually zeroed in on this before that call, I think. But who was
there was somebody else who had issues, and we talked about it. Wasn't Jim Harrington? It wasn't you, was it?
No, I don't know anything about Botox in the bladder. No, it was not I.
Okay, how about who's the fellow from Australia?
Oh, that's right. Yes, thank you. It was Jim Marshall. Quite right.
Yes, right. And I think I had already
very good.
Been thinking about Botox, but he suggested
that's right
a different cocktail.
Yes.
So I should, for the rest of you, before the surgery, I was undergoing something called bladder installations every week, where a solution of lidocaine and sodium bicarbonate and heparin, was placed through a catheter into my bladder for about 20 minutes, and then then it was drained out. And that's something, Jim, that you also might consider. so, you might just ask your urologist if he thinks that since there's damage to your bladder, that whether bladder installations might be appropriate. I think they, my less educated guess as a layman would be that it might very well help you. So that it's not, just to be clear, installation is INSTILL, and not, it's not an installation, INSTALL. So, I would take that to your urologist and see what they think.
I got an appointment to see him a couple days before Thanksgiving, so.
Yeah.
So Jim Marshall, that's installations and also the Botox conversation. Go ahead, Bill.
The Botox, the cocktail. Oh, sorry, no, we're talking about the Botox now.
Yeah.
I think I was finished. So
okay.
The Botox would, yeah. So what I was going to say is that the installations, can be performed with a number of different cocktails, and I think that Jim Marshall, whoever was in on that call, was really helpful by suggesting a different cocktail than the one I was using.
That's exactly right. You're exactly right. I remember now. Now, Bill, what we were discussing before you got on the call was this new drug that Jim Harrington has been using, which Myrbetriq, MYRBETRIQ. I think it's Mirbigon is the general name for it.
Oh yes, I'm very familiar with it.
So you are. So maybe because Jim Cameron had actually started the conversation by asking about Myrbetriq. You want to talk about that a little bit?
Okay, so Myrbetriq is an antispasmodic. One of the drugs that I was suggesting a few minutes ago might be helpful, and so I took Myrbetriq. Usually, I think the protocol calls for starting out with 25 milligram tablets, and I think this is when I've turned on my computer and entered the call. I think you guys were discussing 25 versus 50 milligrams.
Correct.
And I think the protocol usually is you start out with 25 and work your way up to 50, or take the 25, see whether or not it works for a week, and then go up to 50. At least this is the protocol that we followed, and it worked too, but it has side effects, and it just dries you out. And I'm trying to remember why did I. So I eventually had to stop taking it, and I'm trying to remember what the problem was.
Yeah, that's funny because I took it. I still take it. It never dried me out. I don't know, but I only when I heard about maybe that one, but was the higher blood pressure. Did your blood pressure go up any, or?
No. That didn't happen.
Now
I think I'm confusing Myrbetriq with another anticholinergic.
I think so, because that was the trouble that Jim had when he took the first drug, which was it? Did you say oxybutane, Jim?
Oh yeah,
oxybutane.
No, it's oxybutynin. Yeah, that's an
5 milligrams.
Yeah, that's an anticholinergic, and that it just it shuts down the production of water everywhere in your body. So
yeah, that's exactly what it did.
It can cause dry mouth, which can be severe. At least it was in my case. So the Myrbetriq is, is something that, it doesn't. I was getting confused there for a minute. It doesn't have those side effects. It's terrible. I can't remember. I think I'm really cognitively.
You're doing fine. You're doing fine. There's a lot of drugs that you take and keeping them, but it's interesting because you and Jim Cameron had exactly the same response to the oxybutynin. Jim Cameron said he had to stop after 3 days, which is why he's now looking at the Myrbetriq, which for him is very expensive. And so, the question was, is it worth his while pursuing the Myrbetriq, and Jim Harrington has had good experience with it. And how was your experience with the Myrbetriq? Did it help you at all?
I didn't take it long enough for it to be able to tell. And I'm blanking on why I could not take it. It's terrible. I just do not remember.
Oh, it's also very expensive. If you had to pay for it, maybe that was a reason.
I have a big pile of pills that I take, and I just can't. I will, if it's important enough to you, Jim, I can go. I can ask my urologist. I have a meeting on Thursday, and see if they're in their notes they indicated why I had stopped, and then let you know.
Yeah, I'm interested because I had such bad effects on the first drug, and like I say, this other drug is quite pricey. Plus, I don't want to go through what I went through with the first drug. I mean, it took like a week for my system to rebound from it.
Yeah, the oxybutynin. I actually took the oxybutynin, your first drug, for about a year and a half. But then it just the dry mouth in particular became too big of a problem. I couldn't speak. It was, but it did help. That definitely helped. It's too unfortunate that it had those side effects. I just wish I could remember why I had to stop taking them.
I know both my urologist and primary care doctor told me that a great percentage of the people they prescribe this drug for, when it works real good, but a high percentage have the side effects that I have and have to stop in a short period of time.
Now you're talking about oxybutynin or
oxybutynin.
Oxybutynin, yeah.
Oxybutynin. Bill, I've just sent you a message with Jim's email address.
Terrific.
So you have it there, so you guys can get back to each other, and
any help you give me would be greatly appreciated.
Okay, I will be in touch. I can't promise that I can help you, but I'm sure going to try.
So, Bill, just to finish up on this subject, how are you doing now after your various procedures? Is it too early to tell? Are you getting any relief? Has it been worthwhile? How are you? Where are you?
I think it's too early. It's been a tough ride. It's been I think the surgery was 2 weeks ago this past Friday, and I'm in a significant amount of discomfort. And some of it is just, it was a much more, I'm looking for I'm having difficulty finding words. It was a much more complicated surgery than, we expected. And it was, there was a lot of trauma in there from the surgery. So it takes time for, for healing to take place, Rick. No, I think it's just really too early to tell whether or not it worked. And that goes with the Botox too. I mean, since that was also designed to, the big problem, my big problem is pain, and I think it will be fixed. I'm pretty confident that in another couple of weeks, the next time I talk to you guys, all these problems will be fixed. But right now, so the other thing, Rick, is I developed another UTI after the surgery, and this is kind of interesting. It was probably because the urinary stone that I had was of a particular composition, so it had a lot of a substance called carbamate apatite, which is produced by bacteria, or by bacterial enzymes, more properly speaking. And as the stone is produced, it encapsulates some of these bacteria. So it's like a nest of bacteria just waiting to infect you. And then when they take it out, it usually breaks open and releases all this shit into, the urethral area. And
Right.
so I think that happened with me. So I'm back on potent antibiotics, and, I just started today. So I'm hoping that by tomorrow morning I'll begin to see some relief.
Yeah, it's sad to hear that, and I am sorry, and you're not alone, because Rob Beniscus has been going through much the same, and finished up going to the hospital last week, and going to the emergency room, and so I'm going to I'll post this recording later on tonight, and I will tell him that he should be listening to it, at least the first 45 minutes. We're going to move on because we've got a few guys, and I think this has been a really good discussion, and I know it's going to be helpful to people like Rob who wrestle with these issues. So I'm going to be sure to identify when I post it that we had a good discussion around some of the urine issues.
Just one more minute before you move on.
Yes,
what was it that sent him to the hospital?
I beg your pardon?
What was the problem that led to his hospitalization?
A UTI. It was a UTI issue. It was a urinary tract infection. And what caused it, we don't know. But
Do you know what the bug was?
No. But again, you can certainly. I'm sure he'd love to hear from you. Drop him a line again. I'll put.
Yeah. Okay.
I'll put his email address in the box there for you, robb@ancan.org, and I'm sure he'd love to hear from you since you guys have similar issues.
I mean, the bug that I'm infected with is a rare bug called Ericoccus urinae that is really problematical, and it's interesting because I'm breaking ground here in many respects. The urologist had never seen an infection with this bug before she saw me, and now she's seen several other cases since.
Wow!
Diagnosed. So something is going. There's something. There must be some common denominator. But anyway, it would be. I think it would be useful to talk to Rob, maybe for both of us. So.
Absolutely. And let me. Where's my phone? Here, I'll put his. I'll do it in a second. Let's just get going with the next person, and then I'll put his telephone number in there for you as well.
Sure.
So, Eric, where are you? Can you switch on, Eric? Hello?
Yeah, here I am. Can you hear me?
Yeah, where are you?
I made it home already.
You made it home. Fantastic. Okay, once you got onto the bridge, you flew home, huh? No wait on 24.
Yeah, there was some car stalled right at the beginning of the bridge, and then after that, everything went great.
Okay. All right, well, you're up. Talk to us.
So I met with Dr. Agarwal today.
Oh, right.
And we went over sort of went over the scans, and he said that it looks like, that nothing has changed. So it's holding it in check. So on the basis of that, I'm going to continue on the experimental drug. He said that there is upcoming a trial of an immunotherapy drug, and he'll keep me in mind for that. Mm-hmm. But as long as this is keeping the cancer from growing, there isn't any reason really to switch. Although the immunotherapy would, if it works, would actually get rid of it. But my PSA is still, for me, relatively high, but it quit going up by leaps. So I had both the Berkeley people took it, and it stayed around 8.5, and we didn't have the results yet today. So
okay.
I don't know what it was in the city.
Or you'll let us know. So for those of you who are not up to date, so this is a what's called a BET inhibitor that we've discussed a few times on this call, and the code name is GS2849. Who's the manufacturer again, Eric? Do you remember?
Yeah. Oh God, it just went out of my head. I'll think of it in a second.
Okay. No.
Starts with a G.
Smith, I think.
Glaxo, yeah. GS could be GlaxoSmithKline, yeah, probably.
Well, it's Gilead.
Oh, Gilead.
Yeah.
Okay. All right.
Rick, what is the name? Rick, what is the name of the drug again? Can you tell me?
Yes, it's GS2849, and although you don't remember, I do. You were the one that gave us a very good explanation of how it works.
Oh yeah, no, I remember this time. I just don't remember the name of the drug. 2849.
Yeah, GS2849.
Yeah, this is a really exciting new class of drugs that attacks things at the level of chromatin, or the proteins that bind to DNA.
Mm-hmm.
So, Eric, it's working? Is that what you said? Your PSA is remaining stable or going down?
The PSA is stable and the cancer is stable. The scan showed that the cancer is stable.
And are you taking any other drugs?
Lupron, just.
Just Lupron. Okay, well that's, and you presumably before you started taking this drug, things were your PSA was increasing, or scans were showing.
Yeah, absolutely, and the PSA was increasing and the cancer was spreading.
Oh, that's terrific that it's working so well.
Yep.
Yeah, that is good news.
It is
Yeah,
great.
I'm going to go back, Rick, and re-educate myself about this drug again.
And then will you share that with us and give us an update, because we need the re-education too.
Yeah, I will do that. I promise.
Thank you. So this is 3 months that you've been taking it now. Is that right, Eric?
Yes, that's correct.
And how about side effects?
Well, I've had a terrible problem with shortness of breath and stamina.
Right.
And Dr. Agarwal kind of admitted today that it could be a side effect of the drug.
Mm-hmm.
But I had the problem before I started the drug.
Right.
Oh, okay.
That's why they switched me to Zometa. They said, that maybe it was being caused by what's the other one, Exchiva?
Yeah.
Yeah. And so they switched me to Zometa, and it didn't change at all. So, I mean, if I do anything physical, I went out and trimmed the bush, and then it totally exhausted me.
Mm.
But you had that problem before you started taking this drug. Is that my understanding?
That's correct.
Yeah.
Yeah, I've had that problem for about 1.5 years.
As simple as it sounds, Eric, it wouldn't surprise me if this is a result of long-term hormone therapy, because it does affect some people like that.
Right.
I mean, I know how exhausted I was towards the end of the 2 years that I was on that drug.
Mm-hmm.
And we look for all these fancy explanations, but just the lack of testosterone in your body, it might just be that's the way it's affecting you. There isn't much we can do. Now, that's the fatigue, the shortness of breath, I can't explain. And shortness of breath was not an issue I ever experienced.
Yeah, that sounds a little bit worrisome, though, the shortness of breath, because I mean, there are some serious causes of that, like a pulmonary embolism. But I think if you've had
I've had CT scans for that twice now.
Okay.
Yeah, I passed out at the when I was getting my Lupron, and they sent me immediately for a CT scan, both of my brain and my chest, to make sure I didn't have a brain tumor or a embolism. And so I've been checked a couple times.
Okay.
I've also had an echocardiogram. I've had a cardio stress test. You know, I've had all those things done, and you know, they all say, oh, you know, you're perfectly healthy in terms of that. So
testosterone, androgens in general, are required to maintain, I'm sure, Rick, you know this, to maintain muscle mass. Mm-hmm. And actually, you know, they're required to maintain all the components of the musculoskeletal system. And so, you know, almost certainly that's the cause of your fatigue. I mean, it's a common problem with guys who have been taking anti-androgens or you know, drugs like Lupron for a long time.
Right.
I learned this when I was being treated a couple of months after I was diagnosed with prostate cancer. I had a different tumor dug out of my quadriceps at Sloan Kettering, and they sent me to their rehab medicine clinic, and they treated me for a year with PT, physical therapy, you know, a rigorous program to maintain muscle mass. And so, you know, that's something that you might want to talk to your doctors about too. If you know, if you basically the idea is to do enough exercises to take up the slack gaining muscle mass, but under the guidance of, you know, a physical therapist who knows a lot about the drugs that are used to treat cancer.
Okay. And of course, I agree with all of the above that Bill said, and we've talked about it with Eric a few times. I mean, I do think, Eric, that home-based AbbVie program, the MAN plan, might be something for you to consider. I think we've talked about that before, because you know, you can do it at your own pace, and it's basically resistance, and it's designed exactly for maintaining muscle mass.
Okay, I'll have to look into that.
So, I mean, if you the URL for it is the MAN plan, and all one word. And then if you think it's something you want to do, just let me know, and I will give you the telephone number to call to get an authorization code. And it's a program that's sponsored by AbbVie, who makes Lupron. There's no cost to it, and they're sort of trying it out. It's sort of a trial, and they're working with Answer Cancer and others, but we're sending men their way that we think might be good candidates for the plan. I don't know. Is there anyone else on the call who's got a packet from MAN plan yet? No. Okay. Tom Van Sant, I thought you were going to go call MAN plan.
Hey, Rick?
Yes.
That's what I thought.
I just wanted to.
Yeah.
Rick, it's Eric. I wanted to correct one thing. The drug is GS5829. Just GS. Okay.
What I've got is GS2849. Is that wrong?
Wrong. GS5829.
Okay, thank you.
Oh, great. Thanks for the correction.
Thank you. Okay, I've got it right in my notes now. GS5829. Thank you. Okay, poor old Bill, just as well we told him, otherwise poor old Bill would have been searching for this till tomorrow morning.
Yeah.
no, and not figured out. Okay, we'll move on a little bit. Jake, take some time.
All right. Well, first of all, I had a kind of I don't think it's related to prostate cancer, but I had a scary episode on Saturday. I was eating some pancakes, and I couldn't swallow them. They just felt like they got stuck in my throat.
Ooh.
So then I took a sip of like a sugar-free drink, and I spit it all up, and I actually thought I was going to pass out because I was afraid I was going to actually choke, and I went out to get my wife to do a Heimlich. But by that time it had passed. But it was just very scary, and I don't know what caused it. I doubt if it had anything to do with prostate cancer, but I don't know. But anyway, the last time for those who weren't here, the last time we had a session, Rick had set up a briefing by Foundation Medicine to talk about their gene tests, and I'm interested in the Foundation Act, which is the one for what Rick calls the liquid biopsy, because I don't have a good tumor sample to give. And then I went to the on-site to the site, and I looked at their sample reports, and all they have is lung cancer and unspecified cancer. So I called them and asked them if they could provide a Foundation Act sample of a prostate cancer patient, just to see, do they just recommend the standard drugs that we all know about, the Zytiga, the Lupron, the Xtandi, or do they actually recommend some exotic ones like the GS58829 or whatever? So anyway, I thought a prostate sample for an actual patient with the name and specifics, blotted out because of the HIPAA issue, and they said they would get back to me, but they haven't yet. So I didn't pursue it because Rick said he was going to talk to the gentleman from the site tomorrow, and hopefully he'll have more sway and get them. I just think a lot of us would be interested in seeing an actual prostate cancer result to see if it's actually of any value.
Yeah, and I will when we were setting this up and I was talking to David Marshak, I actually said to him that it would be great if we could have a prostate cancer example rather than just what he had online, and he said he thought he could do that. Having said that, it didn't get posted, or he didn't send us one. So for sure, I think we can get one that will be that will be redacted, and we'll be able to. I'll be able to circulate that around. And I've actually just made a note to remind myself in the conversation with him tomorrow to ask him for that. There's a couple of other things that I'm hoping to address with him. So if there's anybody else that has anything that they want me specifically to talk to Foundation Medicine about, the one thing I will say, and Jake, I think I copied you on that, was that we got a response from the doctor who had sort of, to put it bluntly, stiffed us at the last moment, which is why David Marshak sat in. And he said that the liquid biopsy is not a very good option if you have very low tumor burden. It doesn't do a good job. So because Paul Frieder had asked that question, he has almost no, I think he has an insignificant amount of prostate cancer because he's still hormone naive. And so they said, well, and we put the question to Mughal, Dr. Mughal, about whether it would be worth his while doing a liquid biopsy, and they said no. Now, in your case, there's obviously more going on than with Paul, and I think that probably if you want to go to the next step and consider a liquid biopsy, then we can go back to Foundation Medicine and ask them whether they think it would be worthwhile in your case or not.
Okay.
I think that's difficult. This is Bill. I think, they're selling the liquid biopsy as a way to get around the problem of low tumor burden, and in part. And so, the basic problem is you need enough tumor cells and enough DNA. I mean, what it's really capturing is DNA to be able to do the test. I mean, you know, it's a super sensitive test, but you have to have something in the bloodstream to test.
Sure.
But how you know, how that relates to tumor burden, I think would be really hard to predict. And my advice would be to, you know, if your insurance company will pay for it, just go ahead and have the test and see what results you.
Yeah, I mean, I'm empathetic to what Bill says. I mean, the other reason why some people might opt for a liquid biopsy is because their tumors may be in too sensitive a place to biopsy, or as has happened with a couple of guys I know where they have biopsied them more than once and they just can't get a usable sample out of the biopsy.
Right.
Yeah.
Dr. Steve was one of them, I believe, wasn't he?
Yeah.
So how do they determine if you have a tumor burden? Is it based on your PSA or just the number of metastases you have? How would they determine if you're a good candidate or not? You mentioned when you sent me the email, you mentioned PSA.
Yeah, but you know, PSA is not a great guide. I mean, look at Eric. I mean, Eric's a great example of you know, he's a low producer of PSA. I don't know. I mean, my guess is, this is just a guess, it would be some combination of known tumor locations and PSA history. I don't know. Bill, do you have any idea how they guesstimate?
I have an idea, but I'm not sure how accurate it is. But you know, I'm guessing that they also do morphological measurements using scans on, you know, just taking physical measurements of tumors, including mets.
Yeah.
But I don't know for sure that that's the way they do.
Well, that's not part of the foundation medicine.
Well, no, I mean,
no, they won't do that for you. No.
No, but
it's something that might come out of. Oh, it will. I mean, your urologist or oncologist should know that. They should be able to tell you what they think your tumor burden is.
Right.
However,
Rick, I wanted to make a suggestion when you do talk to him. It would be very helpful to see the 60 sample test and the full sample test, and be able to compare them side by side to see which ones, you know, are they identifying in the liquid biopsy? Are they identifying really the actionable genes, or do they miss all the actionable genes that you can only find in the full scale test?
So in other words, how does your question is, how does the report on the liquid biopsy differ from the report on the solid biopsy? Is that right?
Yeah. Hopefully they catch, you know, all the actionable genes with the liquid biopsy, and hopefully that's the ones they're going after, and that's really the only ones that we'd be interested in. You know,
well, the whole idea of this test is, you know, to identify actionable genes.
Right.
So anything on the panel for either the liquid biopsy or the more comprehensive panel that they use, you know, with tissue samples, all the genes are going to be, you know, actionable by one drug or another.
I understood him to say last week that a lot of them were not actionable yet. They identified them, and they could you know, identify them and list them, but they really didn't have any test for them. Okay,
that might be that they might be hoping that a test, you know, that they'll be actionable in the near future. But
right.
Still, you know, there's no point in testing for something that, you know, is going to be meaningless in terms of your treatment.
All right.
So there must be some reason why they, you know, put the genes that they do on the panel. But I wonder. My understanding was that the set of 60 genes that they use for liquid biopsy were a subset of the genes that are in the 360.
Yeah, they are. What he said was that they are what they consider to be the most frequently significant and actionable genes. So that they are definitely a subset. Now, you know, the issue that we're raising here is is every gene actionable? Well, let's just take an example of a gene that I've heard frequently, but I'm sure Bill knows a lot more about, which is P10, PTEN.
Yeah.
And that was a gene that was highlighted as being mutated in the case of Dr. Steve. But the problem right now, as I understand it, is there isn't a heck of a lot that can be done to capitalize on a mutation in P10. Do you know anything about that, Bill?
No, I don't. I think that's correct, that there really isn't much. There aren't any drugs that that potentially could target that specific mutations in that specific gene.
But there's lots of work on it.
I'm forgetting, Rick. I think, the other reason why you have this test on is for prognostic purposes too. And so some of the genes, might be there just because it's useful to, plan treatment,
right,
even if it's not actionable, to know that,
right,
there's a P3 gene that's mutated or a P10 gene.
Right.
Yeah,
right.
So.
But yes,
again, that's why I want to see this. I'd like to see a sample, an actual test of a prostate cancer patient, you know, just to see what do they identify, what treatments do they identify.
Absolutely.
Is it all just going to be the standard treatments that we already know about that our oncologist is going to try anyway, or is it some exotic thing that nobody knows about?
I think that's a great idea. I'll be looking forward to seeing a report like that if you're able to get a hold of one.
We'll get one.
In the meantime, for the next meeting, I will also get the list of genes associated with both and just take a look and see, whether or not I can make a little bit more sense, at least for myself.
Excellent.
About, why they're picking the genes that they do for these panels.
That would be very helpful.
Yeah.
You mentioned, Bill, insurance. Just when I talked to it was not David. When I called the customer support line, and I asked about insurance. I wanted to confirm what David had said, and because he said right now that if you have Medicare does not cover it, but they do not back charge you. In other words, it's basically a free test if you have Medicare as your insurance now.
Yeah, terrific.
Yeah, so for anybody on Medicare who thinks this would be worthwhile, now's the time to do it because they're trying to get Medicare approval. And, of course, when that happens, then you're subject to the 80% copay business.
Right.
And
that's really generous of them.
And if you're not on Medicare, then they do have a subsidized program. And I think what he said is that it finishes up costing you about maximum $500 out of pocket, I think.
Oh, okay.
Well, they charge insurance. They charge $5,600, and if you're on your own, they charge $4,600. Now, how much of that you actually pay, I don't know.
Right. I think
that might be where the 500 came from. 80% of 4,600.
Yeah, I think he said that they will subsidize you, but you may finish up still paying about $500 out of pocket. So, but anyway. We'll move on a little bit, and we may have some time left at the end, so if so, we can come back to some of these issues, but I just want to make sure that I give enough time to everybody. And speaking of the Foundation Act biopsy test, Mike Tamales, did you get your results back from that test? Because didn't you send them a sample?
I don't know who got the results. I didn't get the results. I guess my doctor got them.
What I would suggest is to call the doc who sent the test and ask him to give you a copy of those results. And then if you send them to me, I can circulate them to a couple of people like Professor Bill and some other people, and we can at least come back to you and give you some help, because I know that I think that Peter is still away for another 2 weeks, if I'm not mistaken, maybe 3.
Yeah, yeah, something like that.
So, will you call the doc? Will you call the doc and ask if he got the test results?
Okay.
And ask him to send them to you too, not just tell you on the phone what they are.
Right. He needs to send them to you both in a hard copy, and he needs to email you a copy that you can send on to other people. Okay, Mike?
Okay, I'm writing this down.
Good. Well, that's really good. So yeah, ask him for a copy of the Foundation Act, because the test that you did, the first test didn't show much, but it was a very old sample from 3 years ago. And then, as I recall, he said he would follow up, and they sent a vial of blood. And that's the liquid biopsy, or the Foundation Act test, Foundation Act. And that's what we'd like to see the results of.
Okay.
So tell us how you're feeling and what's going on there.
I'm feeling okay, considering I'm on my I'll be on my third shot of Zyfigo in 2 weeks.
Okay.
My what's it called? My PSA dropped a little bit. From let's see. Dropped from 73 to 69.
Okay. Which?
And the PSA.
Mm-hmm. And how about your alkaline phosphatase? How was that doing? In the last test, it was 138, I think, before.
It's the same in this one.
Okay. Which basically says that, I mean, it's good in that certainly not getting, you know, it's not progressing, which is a good sign.
Yeah. No, just see what happens this next blood test.
Okay. And when's that going to be?
Let's see, in a couple weeks.
Okay. So if you've got any questions during this period, don't hesitate to call me or to send me an email, and let's see if we cannot get our eyes on this report that that they just provided, that they should have provided by now.
Okay.
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 That's what I want. That's what I want to hear. Some enthusiasm. I want to hear some enthusiasm.
You don't get too excited, Mike.
Yeah.
Slow down, buddy.
No, I'm actually pretty stressed out about this disease. But
Yeah.
I'm just go with the flow right now.
Okay. Okay.
I don't know what the next step is gonna be, but I don't know. And I do get short of breath just cutting one bush, where I used to do the whole yard in half a day, and give me a bush to cut, and I'm like, yeah, I'm ready to pass out.
Well, one thing is that you know you're not alone, as you heard today.
Yeah, yeah.
So.
Yeah, it's actually Yeah, I feel a little bit better. But it's just the energy level and the usual stuff.
Well, you're another guy that maybe could benefit from the MAM plan.
Yeah.
You know, I keep pushing it because I think it's a good idea, especially for people that, you know, are having issues about getting some exercise into their routine, although we know how with you, we just got to get you down to the water and onto that stand-up paddleboard.
Yeah. I don't know where the time goes. I'm monkeying around with insurance also. My insurance is going to run out in April, and I'm not sure what to do.
Well, let me tell you one thing that you can do, and we'll work with Peter, but you've got to remind me about this because I don't always stay on top of things. You should be approved for disability, are you or not?
Yeah, I am.
Okay.
I'm on disability.
And when does your Medicare kick in?
It kicks in September of 17, but I lose my coverage in April.
Okay. So you've got to find a way to cover that April through September period.
Yeah. And then I don't know about, you know, signing up with the Obamacare or what to do. The lady told me just come down a month before you expire and fill out an application. And
all right. Well, it's on my radar. I will talk to Peter about it, and let's, you know, we'll start thinking about how we can connect you to try and get some help for that 6-month period. I don't have anything off the top of my head that I can think of, and you know, what it may mean is that you're going to have a high deductible and take care of your drugs during that period. But if we know what drugs you're taking, maybe we can get you into some trials, or we can work with some of the insurance companies. But I certainly would not be waiting until a month before. That I can say. It's something that we start to need to look at, you know, right now for April.
yeah, and yeah, it's another world out there trying to figure out which drugs and which doctors and which clinics and
right.
Yeah. So it's a little overwhelming.
Okay. Well, let's we'll certainly. I've got a couple of ideas, and we'll certainly see what we can do, and we'll go from there.
Yeah.
Okay.
Okay.
Yeah.
Other than that, everything is pretty all right.
Well, are there some good things? I hope there are some good things going on there, Mike.
Yeah. Yeah. Yeah, I don't know. I'm just stressing a little bit.
Right.
Yeah, the insurance is starting to keep me up at night.
I'm sure. Well, You know, go down to the beach and get on that paddleboard for half an hour. That'll make you feel better.
Yeah.
I'm serious.
Yeah, I know it well. Yeah.
You know, take an hour and a half out of your day, put the board in the back of the truck, drive it down, get on the board and come back home, and you'll feel like $1 million.
Yeah.
Seriously. If you want to.
Yeah. Yeah, I just getting out the old tanker and paddling it right around would be fun.
There you go.
Yeah.
All right.
I don't know, Mike, I feel badly for you. It must be tough. You know, doing this all alone. I mean, aren't you're living on an island in Hawaii, and
yeah,
and there's not a lot of other people around. There's certainly doctors.
Yeah, I don't have much of
I think all of us are
choice.
Hoping that you know, things will begin to work out well for you, and you know, as soon as you can get that report from the doctor, you know, if you can share it with us, that might be a big help. At least you'll have some idea of, you know, where you might go in the future to solve some of your problems. But anyway, I feel badly. I wouldn't. I have lots of support around me because I live in a big city, and you know, I can imagine how tough it is.
Yeah. What you see is what you get.
Yeah. Well, hang in there. Get us that report, and Peter will be back from Vietnam and Cambodia in a couple of weeks, and in the meantime, we're around.
Yeah,
okay.
That's why I'm here just about every week.
Okay. All right.
Okay.
We're going to move on. Ron Zechmeister, give us an update.
Okay. Presently, I'm on bicalutamide 50 milligrams as a monotherapy. I had my PSA had started to come back again 2 years ago. You know, I had gone through the surgery. I'm diagnosed as metastatic cancer, but it's micro metastases, which doesn't have any identifiable tumors. And it was pretty responsive to, you know, I had gone around in that phase 2 study with the Lupron and the radiation and the chemo. And after that, it had pretty much stayed down my PSA stayed down for about 3 years. But then about 2 years ago, it started to increase again. And 2 years ago in the fall, it was starting to go up fairly rapidly, got up to 7.5. And we decided that it was time to go back on Lupron, and which I did. And what the plan was going to be to do the Lupron as on an intermittent basis, where I'd be on for like 8 months, and then get off and see how long it took for the PSA to come back again. And so I went on for 7 months, and I responded real well. My PSA dropped immediately to undetectable. And then after about a year, it started to creep back up again. And by last March, it had grown, it creeped up to about 3, and kind of on the edge of whether I felt like, you know, starting Lupron again or not. And so we decided to take a shot at bicalutamide instead of going on the Lupron. And lo and behold, I responded real well to the bicalutamide. PSA at my last test was down about like 0.15. And so I'm kind of like the poster boy for bicalutamide at this point, which is, you know how bicalutamide works. You get to have the testosterone in your body, you know, as well as suppressing the cancer. So I get to enjoy the benefits of testosterone, and having been on Lupron, I know what it's like not to have testosterone. And so, you know, so things have been kind of good. The only side effect I have is basically is I have tenderness in the nipples, and I've been keeping an eye on them. I don't want to see any breast growth, which I have not seen, but I do have the soreness. But other than that, it's going well. You know, I hate to take up a lot of time on the advanced call here, because I know the rest of the guys are in a lot more dire straits than I am. But I'll be there. I know I'll be there at some point. So.
Well, look, first of all, Ron, you're not taking up time, and everybody has their own situation, and you have advanced cancer, and there's a lot of wisdom on this call, and you know, there may be ways that things we can discuss that may help you. I mean, it's terrific that this intermittent hormone therapy is working for you, particularly with the bicalutamide, the Casodex alone. Where is your PSA? You said it got up as high as 3.0 by mid-2015 when you started taking the Casodex, and where's it down to now?
Well, it had got up to about 3 by last March, and then when I started taking the Casodex, it dropped right off, and it's down now. My most recent test was about a month ago, and it was down to 0.15. So it's responding real well so far.
Okay. And you've been on it for...
I don't know. Well, I'm going in every 3 months for a check on. Right. And as long as I can enjoy the benefits of taking the bicalutamide and having the testosterone, I mean, it's the best of both worlds. So, you know, as long as that continues, I'll continue.
Right. And is it Bloom? You're seeing Bloom, right?
That's right. Yeah.
I mean, he's a really good doctor. So you know, you're in great hands with Bloom.
You know, I have a comment I'd like to get your opinion on. You know, the whole idea. You know, like I have, we call it micrometastases, right?
Right.
And I've always been suspicious that it's simply metastatic cancer that you can't pick up on a typical CT scan. So I'm guessing probably if I do the C11 choline test, that, you know, yes, indeed, there probably be some pockets out there that in my body that would have this low level, you know, this low level cancer. So I asked him about that, and he said, yeah, he said the problem with the C11 choline test is that it's, you know, it'll light up some spots, and you can chase the spots with, you know, with surgery or radiation or whatever, and then a year goes by or whatever, and you do the test again, you find some more spots, and then you chase those, and so it's not really like a cure, it's a basically a therapy, an ongoing therapy. And his advice was, as long as I'm responding so well to the you know, the ADT, that it didn't make a lot of sense for me to go through the whole C11 choline thing.
Well, I mean, my question to you would be, if you go through the C11 choline, what are you hoping the result will be, and how would it change your treatment?
See, that's exactly the point, and I don't see it, and I don't see that there would be a result that would change my treatment. So
that's right.
Yeah, so I agree with the whole deal. Yeah.
So just help me with because I'm looking at my notes here, and I just I had cut and pasted something that you wrote to me, but I don't have the time frames. When was it that your cancer got up to the PSA got up to 7.51 before you went on the intermittent Lupron?
That was That was October of 2014.
2014. Okay.
And then that's when we see it. Before that, it had been creeping up slowly, and it got up to like in August, it had gotten up to 5.26, and he said, well, let's try finasteride, and and see if it had an effect. And so we tried it, and it was no effect at all. And then by October, it had grown to 7.51, and that's when we decided we could screw it around and go with the Lupron.
So let me ask if there's anybody on the call that wants to talk to you about this situation, or
yeah, Rick, can I? It's Jim. Can I make a comment?
Please.
I've had some of these same things. First of all, it's good your Lupron results, but in your Casodex, I was on 3.5 years, almost 4 years of triple dose Casodex. So what I was going to ask you is, how much Casodex are you taking? Just the normal amount?
Only 50 milligrams a day. I know when you read the
literature. I took 150, and it really helped. I mean, I went for 3.5 years, and you're quite right. Your testosterone goes sky high. Well, it goes up, and you sort of become a super male. So you don't have, you don't suffer that. But you might ask the doctor if you could always take more. But it sounds like yours is working really well. The other thing, finasteride, is just Avodart, and I take it too. Most of us have taken it. It doesn't do very much. It can make your hair grow, which isn't too bad as a side effect. Unless you're bald. But so I don't know. The only thing, I think your results are really good. The only thing, if you start to fall back and it starts to go back up, you might talk to your doctor about increasing Casodex. The idea of triple dose Casodex is not new, by the way, but it won't cure cancer. But it might. It just, I'm a person who did it. And of course, ultimately, you could go on Xtandi, which is the super Casodex, when you get to that point. But right now, you're doing very well. It's good.
Yeah. I believe all the studies that have yielded the Casodex as a monotherapy as a result have all been based around dosage of 150 milligrams. And I don't know of any that have been based around a less dosage. But my doc, he says, he says 50 is great. You don't need 150. It's doing what it's supposed to do. And I don't know if there's any quantifiable difference between 50 and 150 as far as result. But anyway, for me, 50 is doing just great.
Yeah, then I certainly wouldn't take 3 times that. There's no point in doing it. I mean, it's not a terribly expensive drug, but yeah, you're quite right. And if it works, don't take more. Yeah, I mean, I never had any side effects at all from Casodex, but
okay.
But anyway, good for you. Good result.
And how long?
You didn't have the breast tenderness?
Well, yeah.
Yes, I have. I did that. I have had gynecomastia. I had the radiation for that. But that is that. Okay. Yes, I did. When I started triple dose Casodex, my oncologist here in New Jersey at the Cancer Institute said you should have this, and it's not so common anymore because it's purely a quality of life issue or cosmetic issue.
That's a cosmetic thing, and I don't.
Yeah, but I had it, and but I will tell you one thing, that my nipples also got sore, but after a year or more, that went away. But boy, and you just touch them, and whew. But it does work. There's one of our guys in us too who did not have the radiation. He says that he won't go to the beach and bare his chest because of his breast enlargement. So I don't know, but for me, I've been on Lupron. I've been on a lot of things, Lupron and Casodex, and I have had no breast enlargement. But the gynecomastia is a one-shot deal.
Yeah, I'm 74, and if I go to the beach, I don't give a damn what people think.
Well, that's a good attitude to take. Yeah.
No, it's not bad. It hurts, but not a lot. And
I think that
I've keeping an eye on it, and I haven't noticed any growth. So,
yeah, if you do have the radiation, it's I think I had 3 treatments. It could actually make your nipples even sore yet, but but it's something to keep in mind. I know it's not. I don't think it's quite so common, Rick. I don't know, you know more, but it is a quality of life or cosmetic type thing. But I don't regret it.
Yeah, I mean,
Good for you.
I know several people that have had the radiation. I mean, it's only 1 or 2 sessions, and I don't think there's a lot of downside from it. So,
this is Jake. I have a comment.
Yes.
For Ron. Like Jim, I'm on Lupron and bicalutamide. In my case, in my case, it's not stopping. It's not working anymore. So I'm probably going to have to get off of it. But as far as the nipple tenderness, it does go away. At least it did in my case, just like it did with Jim.
Oh, great. Good to hear.
Yeah. And also, as far as the dosages, from what I've read, the protocol is if it's monotherapy, the normal dose is 150 milligrams. If it's done in conjunction with Lupron, then that's when they do the 50.
Right.
Yeah.
But I mean, I was just going to say, I mean, I think that if Dr. Bloom is trying you on 50 and you respond to 50, more power to him for starting you off and seeing where you went.
As long as it's working, yeah, by all means.
Exactly.
Just to digress for a second with Jake. Jake, have you talked to your doc about getting off the bicalutamide to see if you get a response?
I missed what you said, Rick. You broke up.
Sorry. Have you talked to your doc about getting off the Casodex to see if you can get a response?
No, not yet. I'm lazy. I haven't called her yet.
Well, I would strongly recommend you do that, because when these drugs when the Casodex does stop working and you are taking Lupron as well, like you are, there are some people that do get somewhat of a response from it. Because at some point it switches, and rather than preventing the androgen receptors from feeding on the testosterone, it makes them more sensitive.
Right. I keep meaning to call, and I keep putting it off. But now I'm thinking, based on what Jim said, maybe I should try to ask her about going up in dosage. But either way, I need to call her. You're right. I was going to wait until after Thanksgiving, but I probably should call sooner than later.
I would.
Yeah.
I mean, it sounds like you need an adjustment one way or the other.
Yeah. I guess you heard the last time when Glenn ran it, my PSA has gone up to 5.5.
Right.
It went up 2 points in a month.
That's right. And we suggested that you maybe quit the bicalutamide, but monotherapy might be another alternative, but you can discuss with her. So Ron, look, as they say, keep taking the pills.
Yeah, all right. I do. I'm telling you, I know when I've taken your advice and everybody else's, and I am a believer in exercise. And when I was on the Lupron, I tried hard to exercise, and it was mentally tough. But I did it, and I thought, oh, I'm getting along, I'm doing okay. And but now that I've got my testosterone back, and I look back, I can see how tough it really was on the Lupron. And so I'm, thanking my lucky stars here, I get to have some testosterone in my bod. So.
There you go. Well, listen, don't be a stranger to this group. There's a lot of knowledge here, and you're always very, very welcome. And, dial in whenever you feel like it.
Yep, certainly will.
Yeah, Ron, the other thing is you said you feel like you might be wasting everybody else's time. I can tell you that it's always good to hear, a good story of the things that are working from another patient. So, I would continue to call.
Absolutely. And it gives me a good opportunity to give a plug to the Give It to the Max Day, which is coming up, I think, on November 17th. It's a Minnesota thing where they devote a day to nonprofits and schools and what have you, and they encourage you to give. And depending on how much is raised, the nonprofits get thrown into pools where they could get more money. So, and this is something that Rob Banisca's picked up and put us on, and Ron Zechmeister is a Minneapolitan, and but you don't have to be in Minneapolis to help us. So if you were thinking of making an end-of-year donation, go do it through the Give It to the Max Day or Give It Max Day, which is linked on our website. And Tom Van Zandt, yes, I got you to lift your head. There you go. Okay.
I've got to drop off now, but thanks you guys. Thanks a lot.
Thank you, Ron. Take care. Tom Van Zandt, have you got? You joined us a little late, so I didn't ask you. Did you want to talk to us about anything today?
No, my problems are the same as the other fellows that were talking. I've been on Lupron a long time, and I have fatigue and no stamina, and tired, sleepy.
I know.
I mean, I do exercise too, but and then I start to feel good. I'll have a couple good days, and then I'll have a lot of bad days. But I had like just recently 3 very bad days where I'd get up. I feel okay when I get up in the morning, and I get up and I have something to eat, and then I'm tired and I sit in the chair, and I mean I'm exhausted, and I get up and I have lunch and I go back and I sit in the chair because I can't do much of anything else. My legs are weak and everything else. And that went on for like 2 or 3 days. Then finally I got up and I felt pretty good and I was able to do some things, and I exercised as much as I could. And now today was sort of a so-so day where I got out and I did a little bit, but then I came back and took a nap and fell into it like a death-like sleep. That happens a lot.
Yeah. Yeah. I mean, I'm absolutely sure that it is it's a direct effect from the Lupron, because I know the feeling, and I went through it too. And then when you're on some of the more aggressive drugs that some of you guys are on, it makes it even worse.
Well, I'm on abiraterone. I don't know. I have a doctor's appointment coming up, and I'll probably ask them about going off Lupron and just staying on abiraterone, but I got a feeling they're going to say no, no, no. I had one doctor tell me, oh, you're on Lupron for the rest of your life.
I think that's probably the case. I hate to tell you, but I think it's probably the case because they feel strongly that you've got to suppress the testosterone to give these drugs the best chance to work. When you get to the stage of taking an advanced drug. So did you call the man plan? You didn't yet.
No, that's something that I always intend to do and haven't done.
Okay.
I intend to do it as soon as we get off the phone.
Okay. Well, it's very easy. It's very painless. You fill it out. You give them a call, and tell them you're from Answer Cancer. They'll give you a code number, and then it takes about 2 weeks, and you get a package, and you can start exercising at home. So I strongly recommend it. I'm still waiting to hear from people that have started the exercises. I know Ron Shaheen got his package, but I think he's been I think he's intimidated. He doesn't want to come back on the call until he opens the package and starts doing some exercises. I mean, I don't know, but definitely I think it's a good solution for people that are in more remote locations or it's harder to get to a gym. Any wisdom amongst anybody on the call for Tom on this fatigue issue? Anybody want to say anything about the fatigue or any thoughts? Because it just seems to come up so often. The last 3 guys have all complained about it, or 3 of the last 4 guys have.
You know, Rick, this is Jim. I don't know. I think I exercise and I still lift weights. I don't lift nearly as much. But the key is just to keep exercising. And I find, too, to try to eat a little something in the afternoon, maybe in the middle of the day. I find it can really pick you up. I mean, just a piece of fruit or something like that. But, yeah, I don't suffer too much from fatigue. But I was worse with the Xtandi. But now that I've switched to Zytiga, there really isn't so much of a fatigue problem. But sometimes I think I get a little tiresome. I think I'm just going to battle through this thing. I'm not going to let it get me. And I know just a little bit of food in the morning or mid-afternoon can be helpful.
Jim, are you taking Lupron with your?
Yes, I'm a Lupron lifer. Yeah, I take Lupron and Extiva. For the bones. I had been on Prolia, but they switched me to Extiva. I'm not sure there's too much difference, but so I get Extiva every month and a half and Lupron every 3 months. I've been on a long time. I don't suffer from hot flashes. I just one of these guys. I think everything you've said, Rick, over and over and over is just exercise really is important if you can do it. And
it is.
It really is. So no, but the Zytiga seems to be working, so I'm really pleased.
The only reason I asked you about the Lupron was because you were on the bicalutamide monotherapy for a while.
That's right. Then I stopped that once it really, my PSA got up to about a little over 3. And I mean, I knew it wasn't going to work forever, but it sure was fun when I was on it because you do have your testosterone. But no, then I switched to Lupron and then it failed and so forth.
Okay. Well, you know, I do know that from my own personal experience that as much as you don't feel like exercising, if you can get yourself out for a brisk walk.
Yeah, that's right. Just try to do something, as I say, maybe a little bit of fruit or something in the afternoon. Sometimes you got to say, look, I try to do it. I'm a morning exerciser. I'll start around 6:30 in the morning, and once you get used to, I find it's good in the morning, but it's not everybody's taste to do it in the morning. But I've been doing it so long, and I have my own weights, so I sort of have my own gym. I don't have to go anywhere else, and yeah, just got to do it because I keep saying to myself, look, I'm going to beat this stuff. I'm going to beat it down, and I'm going to get up there and do it. Yeah, that's the way it goes.
Thank you. Thanks for the pep talk.
Yeah, that's a pep talk. Yeah, well, Rick, you're always giving them all the time. I thought I'd give it, but it's absolutely right. Exercise is so important. Do vigorous exercise.
Anyone else? Well, I have. I think everybody's had a chance to speak. There's nobody new that's on the call, and so I think we've been through everybody. I have one piece of sad news, which is that I heard this week that Alex Zeem, who was one of our Australian brothers, passed away on October 25th. He was on our call several times. You might remember he took quite a long trip. He was doing the lutetium PSMA test. It didn't seem to do much for him, and he did take a trip early this year and came back, but it just didn't seem like much was working, and I tried to reach out to him a couple of times, never heard, and so I expected the worst. He was very young. I think he was 58 or 59. I let the guys in Australia know. I let Jim Marshall and Paul Hobson know who regularly do attend. And I wrote to his wife, I think it was his wife, and invited her to the Caregivers call. So I just wanted to pass that on. We've put him on our in memoriam page. Well,
Rick, before you close,
yes.
I forgot to tell you the most important thing.
Yes.
About what's happening with me, and that is that the olaparib, the PARP inhibitor, is still working. Well.
Yes.
Yeah. So
okay.
My PSA was down by half again.
Wow.
It's now about 0.16.
Wow.
Yeah. So maybe at some point in the future we can talk about olaparib again, or PARP inhibitors in general, and try to get more people to, get on them. I think it's a wonderful drug.
Well,
that's great. Congratulations, Bill.
Yeah, thanks.
That is really good. One of the calls that I I do want to set up is with Tom Harding, who is the Senior Vice President of Research at Clovis Technology. And they have this PARP inhibitor that's 3 times stronger than olaparib that's still in trial. Do you remember what it's called, Bill? Rit? It begins with an R.
I'm not going to remember what it's called. I have it in my notes, but
yeah,
I don't remember.
But anyway, so I've got to talk to Tom, and we've got to get that underway. But it's great. I mean, for those of you who have a mutated gene that's in the BRCA pathway, or you have a mutation in the BRCA gene, hopefully it can do as good for you as it's done for Bill. Bill, when do you get scanned again?
On Thursday.
Oh, really? Okay.
Yeah.
Okay. Oh,
yeah. Well, we're doing an experiment. I stopped taking Xtandi, which I don't think was doing anything, because before I started the PARP inhibitor, my PSA was skyrocketing when I was on Xtandi alone. I decided to leave it in the mix, thinking that it might be helping a little bit. But we stopped taking it. I stopped taking it about 3 weeks ago, and so this scan on Thursday will be to, just get an idea of what, whether or not Xtandi was doing anything.
Okay, excellent.
So I'll let you know at the next call.
Please, please.
But I expect it to show, the scan 3 weeks ago was beautiful. Along with a low PSA. Olaparib really is doing a great job.
You're the poster boy, man.
Yeah.
You're the poster boy.
Yeah, and I don't know if everybody on the call knows that this is a drug that I didn't work on the drug in the past, but I worked on the genetic pathways that it is involved in. Yeah, it's just so ironic.
It's amazing.
I wrote a book chapter 10 years ago predicting that PARP inhibitors would be useful in the clinic, and never did I ever expect that it would be useful for me.
Well, they couldn't have paid you enough to create the research you were doing for whatever it did to help this PARP inhibitor, this drug, this protocol.
Right. Yeah, exactly.
So what blood test did you take that told you that you would be a good candidate for the PARP inhibitor? Was that the ARV7, or am I getting confused?
Yeah.
No, that's it's not that test. That's looking for splice variants, I think, in the androgen receptor. I can't remember, but no, this is the test I had was just a sequencing test. They drew blood and sent it off to. There are a lot of companies, like Foundation One, that will sequence genes that are known to cause cancer when they're mutated. So mine was sent to Ambry Genetics, and 3 weeks later I got a report that said that I had a mutation in the BRCA2 gene and 2 other genes as well.
Now, let's just point out that Bill's mutation is a germline mutation.
Yeah.
This was seen as a mutation in a BRCA gene that he had inherited. This is not the same thing as what Foundation One is doing, where they are analyzing the tumor, or SNPs of the tumor, little pieces of the tumor. So most of you can go get a germline mutation, a germline test. If you talk to your doctor, it's a very easy thing to do. And it can be a blood test, it can even be a saliva test, and they can do it. And if they find that BRCA mutation, then it opens up some avenues for you. It's not a very common mutation. I mean, how common is it, Bill? You know this.
It's about 1% of all prostate cancer patients.
Right.
Have the mutation. It's not. I mean, I went to a genetic counselor.
Right.
First.
Right.
And I have an extensive family history of cancer. And,
right.
If you have no history of cancer in your family, then it's probably not. It's an expensive test, and your insurance company probably wouldn't pay for it. But if you go to a genetic counselor, they can tell you whether or not it's worthwhile to have the test, and then if they sign off on it, your insurance company will, almost undoubtedly pay for it.
Right. And the 1% is the incidence of the inherited BRCA.
Right.
I mean, it can. There are genes. There are the BRCA and genes in its pathway that may well show up as a mutation that are somatic driven, meaning that they arise from changes in the tumor itself. So, that's
where the PARP inhibitors become useful for many other guys.
Right.
Probably a large number. It's maybe, I think the numbers are something like 20% of all prostate cancer patients have a somatic mutation.
Right.
That number may be wrong, but it's a significant number, have a somatic mutation in their tumor DNA, but not in their germline.
Right.
And that mutation is actionable with drugs like olaparib too.
Right.
So that makes it worthwhile to have your tumor DNA sequence to see whether or not you have that mutation. BRCA2 is, I'm sure, on the panel, for both the liquid biopsy and the more extensive panel.
And if you want a refresher on this, I recommend you listen to the session we had where Bill gave us a good chunk of his knowledge and made an excellent presentation, and it is posted on the website. You can go back and you can re-listen if you were there, or if you weren't there, listen to it, and a lot of this is explained in good detail. Anyway, guys, look, it's 7 o'clock at my time, 10 o'clock your time, and I even see that Tom Van Zandt fell asleep and switched us off. So,
Hey, Rick.
Yes.
Mike Smallis here. Hey, I found my results from the Foundation 1.
Oh.
They sent them. I just had them filed in a different spot.
Now, is this the new one? The second test or the first test? The second test.
I thought there was only one test.
No, they did it. They did another test. They did your Foundation 1, and they used an old sample, and then they agreed that they would send off a second test, which was just going to be a blood sample.
Okay.
And that's the one that you want to get, the second test.
Okay.
Okay?
All righty. Okay,
all right.
Have a nice evening.
Okay. All right, everybody. Good night.
Good night, everyone.
Thank you.